Welcome to the 18th episode of Late Night Retina. We have a very good session today of the second part of macular hole surgeries. We have some very good international as well as national speakers this time around. And let me introduce you to the moderator, the host for today. We have Dr. Bhavik again. He's a consultant at Vizag LVPI, Vitro Retina. Over to you, Dr. Bhavik, please.
Yes, thank you, Dr. Avnish, and we welcome all of viewers once again for yet another late night retina session, our 18th in number, and we hope to reach 50 as early as possible. So, for this session, we have that is macular hole, complex macular surgeries part 2. We have our panelists, which were there in the previous session as well, Dr. Kushal Delhiwala, Dr. Avnish, and Dr. Chitranjan. Dr. Kushal is a VR consultant at Netralaya Super Specialty Eye Hospital in Ahmedabad. Dr. Avnish is a VR consultant at IQ Super Specialty Hospital in Gurugram. Dr. Chintranjan is a medical consultant at Arvind Eye Hospital, Madurai. Apart from this, we have an exciting young international faculty, Dr. Hung Da Chu. He is an attending VR surgeon at Department of Ophthalmology in Linkou, Taiwan, that is Changung Memorial Hospital. He is also the General Secretary of the Young Ophthalmologist Committee in Taiwan Ophthalmological Society. His clinical interests are in surgical retina, high myopia, and ocular oncology. He has several publications in journals with high impact factors. And why he is here today? One of the reasons is that his recent paper was published in AJ on nasal or temporal ILM flap assisted by sub PFCL viscoelastic injection for macular hole repair. So without wasting much time, we'll straight away go to Dr. Hongda. Over to you, all yours. Please take over.
And good evening, everyone. I'm Hamda Zhou from Chang'e Memorial Hospital, Taiwan. I'm a vitreoretinal specialist and I have special interest in surgical retina, high myopia, and ocular oncology. So today, I'm honored to have the chance to share my technique in macular hole repair for the Young Ophthalmology Society. So our results was published in AJO this year and also in BMC Ophthalmology last year. This technique is called the Subpurple carbon liquid viscoelastic injection technique. So you can take a look at our illustration here above or at our video. So after staining the IOM with an ICG, we start to initiate the semicircular IOM flap in the nasal, superior, or in the temporal aspect of the macular hole. So after creating this semicircular IOM flap, we inverted the flap to cover the macular hole. And then we injected a purple carbon liquid. You can see here the purple carbon liquid nicely flattens the flap against the macular hole. And then we proceed to inject viscoelastic in the interface between the flap and under the OVD, under the purple carbon liquid. You can see here the OVD stay nicely on top of the flap, and the flap stays very secured even during FAX. And here's another video. We can take a look at the technique again. So we injected a purple carbon liquid. So this is a large macular hole, so we protect the toxicity of the ICG staining by the purple carbon liquid bubble. And then we remove the excessive ICG after staining. Because this is a larger hole, we peel off the inferior IOM around the macular hole first. So you can see here, we slowly grasp the IOM and remove it in a semicircular area around the macular hole.
We are unable to see the video.
We further enlarge the peel-off area to decrease
the second video. We are unable to see it. Can you replay the video?
Here's another video. We can take a look at the technique again. So we injected a perfluorocarbon liquid. So this is a large macular hole, so we protect the toxicity of the ICG staining by the perfluorocarbon liquid bubble. And then we remove the excessive ICG after staining. Because this is a larger hole, we peel off the inferior IOM around the macular hole first. So you can see here, we slowly grasp the IOM and remove it in a semicircular area around the macular hole. We further enlarge the peel-off area to decrease the rigidity of the retina to facilitate hole closure after the surgery. And then we started to create the superior flap. So first, we created several strips in the border of the superior flap. And then we grasp the superior border of the flap and slowly peel off this semicircular flap in the superior aspect of the macular hole. So near the macular hole, the flap was translucent because we didn't stain this area. But you can see here, we invert the semicircular flap to oppose the macular hole. And then similarly, we injected perfluorocarbon liquid, and you can see the flap flattens very nicely against the macular hole. And then we inject the viscoelastic in the interface between the flap and the perfluorocarbon liquid to stabilize the single layer flap. And then we can proceed to shave the peripheral vitreous. And we found a small retinal break near the ora serrata, and then we do indentation to confirm. And then we can even apply laser. And you can see the flap stays very nicely and secured even during FAX. So anatomical outcomes, we achieved 100% flap hole closure with this technique in nearly 40 eyes, and the flap was present can be observed at 6 months postoperatively on OCT in 74% of the eyes. Among these eyes, single layer flaps can be observed in 84% and multi-layer flap in 14%. So if single layer flap was maintained, we can see that at 3 and 6 months postoperatively, the ellipsoid zone has a very nice restoration. On the contrary, if it forms a multi-layer flap, although at 3 and 6 months, we can see the hole was closed in a U-shaped configuration, but there is an obvious foveogliosis which interfere with ellipsoid zone restoration. And this gliosis was significantly associated with the poorer BCVA improvement at 6 months. The other anatomical outcomes was comparable to other studies. As you can see here, we achieved a high percentage of type 1 closure, U-shaped closure, ellipsoid zone restoration, and the low rate of foveogliosis. So in conclusion, subpurple carbon liquid viscotamponate effectively secured the single layer flap and achieved a low rate of foveogliosis. It is especially so.
Okay, so Dr. Hongda, yeah.
Yeah, sorry, maybe some problem with my video, but yeah, mostly it's finished. Yeah, so it's especially good for beginners.
Exactly.
So, yeah. Okay, thank you, and thank you so much for having me here today.
Yes, thank you. So a wonderful technique, especially for beginners, as you mentioned, and you also mentioned in the video the advantage of injecting the PFCL and getting 100% closure rate. Dr. Hongda, a question for you is that What are the factors which lead to this foveal gliosis? Have you evaluated them?
Yeah, so most of the gliosis is formed by a multi-layer flaps. So in the older times, we perform like the conventional inverted flap or even flap insertion. So in that manner, it's easier to form a gliosis. It's like a plug in the macular hole area. So it can effectively close the hole, but usually you will observe there's a plug inside the hole. So it will have a lower chance of visual recovery. So that's why now we aim at performing a single layer flap. It can facilitate hole closure, and also it can prevent the formation of a gliosis plaque in the whole area.
Correct. Yeah. So in your study, what you showed in the video is there's just a single layer flap which is overlapped, a semicircular flap which goes over the fovea, isn't it? So how does this multi-layer flap form?
Oh, you mean a multi-layer? How does the multi-layer flap forms?
No, yeah, like in the video, in your technique as well. Ideally, it should be a single layer flap, right?
Yes, right.
What led to the flap in your studies?
Yeah, so even if we stabilize it with both purple carbon liquid and OVD intraoperatively, and the OVD stays there post-operatively, it's still the OVD can be washed away quite early after the surgery because of the fluid current, right? And after the OVD is washed away, the flap itself can fold it upon itself and form a multi-layer flap. So without this technique, it's even higher chances of observing this folding up of the flap. So even if you aim for a single layer flap initially, it looks very nicely during surgery, but it can form a multi-layer flap afterwards. Because yeah, it's a very, very small, a very thin flap. It can fold it up quite easily.
Sure. Thank you, Dr. Honda. I would like to invite a panelist here, Dr. Kushal, Dr. Avnish, and Dr. Chitranjan, if they have any questions for you, Dr. Honda. Yeah.
Dr. Bhavik,
and this technique is called the subpurple carbon liquid viscoelastic injection technique.
Dr. Chitranjan, you can ask, I think.
Yes. No, actually, I wanted to show a small video. Can I show that video, Dr. Bhavik?
Oh, definitely. So, Dr. Honda, can you unshare your slide?
Okay, sure.
So, meanwhile, Dr. Chitranjan can share his presentation. The question is one of the chat box. The question came up. What was the tamponading agent you used? It was on the air or it was gas?
Yeah. So usually we'll use at least gas. And sometimes if it's a very large hole or a recurrent hole or in high myopia, we will consider to use silicone oil, but that's very rarely. So mostly it's SF6 or C3A8, depending on the condition of the hole.
Okay.
Should I play my video?
Yeah, you can just make it full screen. Yes.
So this is a small video, just similar to what Dr. Honda showed. Very nice videos by him. So what I am showing over here, we are staining the ILM under PFCL itself. As you can see, there is a PFCL bubble, and we are using BBG, unlike the ICG that he showed. So small difference. And another thing is that the ILM peeling part I will not show. Directly I am going towards. You can see over here the flap is already there. Okay, the ILM graft is there in situ. I'm just removing the PFCL. There is no use of any viscoelastic, unlike Dr. Honda showed. So the graft is staying there with the help of the tamponade only. That FA that I am using now, with the air tamponade only, it's there and it does not get dislodged. We have done cases with this. So there is no use of any viscoelastic, and we stand under the PFCL. One thing is that we could not achieve, like Dr. Honda showed, the semicircular flap kind of thing, because the ILM comes in a piecemeal. I'm sorry I did not show that thing because of the interest of time, the peeling of the ILM. But yes, this is the slight modification from what Dr. Hangda showed. That's all from my side, this video.
Okay.
Wow. Yeah, this is quite interesting. So you are able to stain under the purple couple liquid.
Yes. You saw that, na? We are doing it regularly, not only in like this was a hole of 830 micron, like large macular hole, where we are planning to put the flap, ILM flap, and we apprehend that the flap may get dislodged. In those cases, we are using this method. And also additionally, as I have told in the last talk also, the diabetic vitrectomy cases, usually the macula will be boggy. So we are putting PFCL and also macular hole associated with post-operative RD, myopia macular hole cases. We have been taught and we are doing like this, the staining under PFCL, and it stains nicely.
So the advantage is that you use a lesser amount of BBG or any other benefits of staining under the perfluorocarbon liquid.
No, the advantage is the amount of dye we are using is the same only. We are using a heavy BBG, as we discussed last time, 2:1 ratio of the dye versus the dextrose. And it stains nicely because in this particular case, the indication of staining under PFCL was not to dislodge the flap, because sometimes without using PFCL, if you are doing at the end of flap inside the hole, we have seen that after the FAE is over, the flap gets dislodged. So this was the indication over here, but other cases, as I told, like myopic macular hole, there the poster pole will be detached. So if we put PFCL, it gets kind of stable. The proliferative diabetic retinopathy TRD cases, where we are doing the surgery, the macula will be boggy. You put PFCL, stain it, do the ILM peeling, you ensure that all the vitreous is out, and it's a nice method actually. It's good.
Yeah, it's a very interesting. I'll give it a try next time. Yeah, thanks for sharing.
Thank you, Dr. Chitranjan. We have one more question from Dr. Kushal for you, Dr. Hungda.
Sure.
Yeah. Great videos, Dr. Hungda. So recently, once I saw your paper, I also came across another paper where similar technique has been used. It's a Polish group. It was published in Retina 2020. So they did not use any tamponade and they closed the case fluid filled. And similarly, they had used sodium hyaluronate as a visco tamponade. So I would like to know your comments regarding that, because they also got a closure of 11 out of 12 eyes with macular hole surgery. Thank you.
Thank you. So I'm not sure which article you're referring to. Can you describe their technique again? Does they use exactly similar method?
Yes. So they also did similar way. The only difference was that you had peeled ILM first and then you had put the perfluoron. They had peeled the ILM under perfluoron, and they also went ahead with the sub PFCL viscoelastic, and they had used sodium hyaluronate while you had used viscoat, and they closed the case only with aspiration of PFCL at the end of the procedure. They did not use any of the tamponades. I will share the full text also and the link to it.
Okay, please. Yeah, because initially we published it in BMC Ophthalmology, also in 2020, and later we expand this technique to macular hole. So previously it was used in macular hole retinal detachment. Yeah, so in that way we can just get rid of the fluid in the macular area, and then we proceed with the further flaps procedures. Yeah, the one thing of if you peel the IOM under the perfluorocarbon liquid, the flap will not stay in a single layered configuration. It will very easily fold it up, and you will form a plug inside the fovea area. So we don't do that. Usually we'll initiate the flap without the tamponade of perfluorocarbon liquid, and then after we form the flap and oppose it upon the macular hole, until then we'll inject the perfluorocarbon liquid to further flatten it against the hole. Yeah, I think it's more easy to form a single layer by this technique instead of peeling under the perfluorocarbon liquid. Yeah, but in cases such as in macular hole RD, that's easier to peel the IOM. Yeah, since there's already fluid in the macular area. So yeah, depending on the condition, I think both techniques is very has its advantage. Yeah, and okay, I'll take a look further into is this the citation?
Yeah, I have just shared the PDF file in the chat
Okay.
box.
Yeah.
Okay, thanks.
So thank you, Kushal, and thank you, Dr. Hungda. So basically, what are the takeaway points? If I have to summarize from the presentation, what you made is that it's an excellent technique for a beginner, in which you can have a nice control over the closure rate or the macular hole. It gives 100% closure rate, as you are certain that your flap is going to stay there with the viscoelastic being there at the end of the surgery. And what I learned from this is that a single flap closure has better visual outcomes compared to a multi-layered flap, and multi-layered flap will lead to a foveal gliosis that may reduce your visual outcomes. So thank you, Dr. Hungda, for that wonderful technique that you showed to us.
Yeah, thank you so much. Thank you. Yeah, I like to add one more thing.
Sure.
Yeah, and yeah, so apart from its excellent techniques for beginners, it's also excellent for very difficult cases, such as if you want to do AMG, amniotic membrane graft, or free flap. You can stabilize the flap very easily by this technique. So yeah. So both in very beginners or in difficult cases, this technique has its advantage. Okay, thank you again. Yeah, and I'm looking forward for the next session, right?
Yes. So we going ahead with the scheduled two other talks. We understand it's quite late at your place. You are free to join and stay back and give inputs on the further cases as well. Okay.
Okay. Thank you. Thank you so much.
Yeah. So next is I would like to invite. Yeah. Yes, I would like to invite Dr. Anirban, if you can share your presentation. So Dr. Anirban is doing a consultant right now at Arvind Eye Hospital in Madurai, and he'll be sharing his video. That is one of the complications in macular hole. Yes, over to you, Anirban.
Hello, am I audible?
Yes, you are.
Okay.
Yeah, your screen as well. You can start presenting.
Yeah. Good evening, everyone. I thank Yossi at the onset for giving me this opportunity to present in the forum of Late Night Retina. So my topic of presentation is keep calm and carry on. So actually, I'm going to show two of my complications which I made while doing macular surgeries, and then how they were managed. So you really need a calm head and a cool mind to manage the complications of macular surgeries, which I realized while doing them. So complication number one. So a 58-year-old female presented with diminution of vision in left eye for 3 months on 7th of August 2019. She was a non-diabetic and a non-hypertensive. Her BCVA was 6/18 in the right eye and left eye 6/60. Anterior segment was within normal limits. Both eye cataract was NS grade 2, and on fundus evaluation, there was a full thickness macular hole of 690 micrometer in the left eye. So this was the OCT picture of the macular hole. So we'll go straight to the surgery. So at 25 gauge, I started at 25 gauge 3-port pars plana vitrectomy. Core vitrectomy was done. Then I injected tricot for induction of PVD. PVD was induced, and then I injected BBG and started peeling. So this was my first macular hole surgery, and I was a little tensed, and you can see my hands were tremoring a little bit. Somehow I peeled off the first flap and then started doing the second. Yeah, so there's the first one. And I peeled off the second one also. Then after a few grasps and a few tries, I got hold of the third flop, and as I was thinking I was comfortable, oops, I almost dug a hole in the retina while peeling. After this, I really got tensed, and as this was my first case, I called my sir, my senior. He came and took over the case after this, and he continued peeling, and he enlarged the ILM flap, I mean the peel. And cleaned off the blood clot, how much ever was possible. Enlarged the peel on the nasal side also. As the bleeding was continuously going on, he cleaned off the blood, and then diathermized the break to some extent because the bleeding was not stopping. And again it bled to some extent, and again he diathermized a little bit. So finally this was the appeal. Then he injected, then he did FAE and dried the posterior pole from the disc and the fovea, and then SF6 gas was injected. So 6 weeks post-operative period, VCVA was 6/60 in the left eye. Retina was on with a type 1 closure of full thickness macular hole with a scar near the superior arcade. This was the picture of the post fovea. Unfortunately, I don't have the scan overlaying the scar of the superior arcade near the superior arcade, but the macular hole got closed in 6 weeks post-op. So after this, I realized, as Aristotle had told, that surface of Earth is not flat. It's a round structure. We should also remember that the surface of eye or the surface of macula is also not flat. It's a spherical structure. So we should always remember that while doing an ILM peel. So we go on to the second complication. So this was a 69-year-old woman who presented with a gradual diminution of vision in the right eye for the last 6 months and presented to us on 4th of March 2021. She was hypertensive for the last 5 years and was on regular medications. Her VCVA in the right eye was 6/60 and left eye 6/9. She had a cataract of NS grade 2 with PSCC in the right eye, and and left eye was pseudophakic. Fundus evaluation, there was an ERM in the right eye grade 1 with a central macular thickness of 564 micrometer. So we go on to the surgery. So there also I started a 25 gauge 3-port Passmann vitrectomy. Tricot was injected for PVD induction. I continued with the core vitrectomy and PVD was induced slowly. Yeah, and this is just slightly out of focus. Yeah, and then the ERM was initially the ERM was peeled off. There it goes. After this, I injected DVG dye. And oops, just when I was injecting the dye, you could see there was a break created just beneath the inferior arcade. There it is. Just a minute, sorry for the. I think, yeah. So just I was injecting the dye, the break, there was a break beneath the inferior arcade.
Yeah, you could see.
So then I took a deep breath. Yeah, yeah. So then I took a deep breath, and however I continued with the ILM peel. Yeah. After completing the ILM peel, I diathermized the break, and then fluid air exchange was done, and aspirated whatever fluid was there from the break, and lasered it off all around the break. And after that, I dried the posterior pole and injected SF6.
Okay.
So this is the 15-day post-operative period. VCVA was 6/36, and this is the post-op picture at 15 days post-op. Yeah. So this was the management of the complication. And so, as Master Shifu says, anything is possible when you have inner peace, and we should always remember that while you're doing macular surgery, You should always maintain a cool head and a calm mind while doing these surgeries, as I realized it the hard way.
Yeah. Thank you, Anirban.
Thank you, sir.
It is extremely courageous to actually show your own complications. It's not easy to come out in the open and show it in the forum like this. So we'll start with the second complication first and then move on to the first one.
Okay.
So the second complication is a digestive injury, and we saw a full thickness retinal break happening there. So this question is to Dr. Avnish. Dr. Avnish, uh, what are the causes? Why does a digestive injury happen, and how? What steps will you take to prevent it? So this will be important for the young listeners who are just starting their VR surgeries and for macular hole surgeries. Yeah.
Yeah, thank you, Dr. Bhavik, and thank you, Dr. Anirban, to actually show these sort of videos where you can actually discuss, because these videos are the ones which actually give you a lot of learnings. So as you have shown it in that, what do you call in your surgery, there is a jet stream injury which actually affects, that there is a breakthrough into the retina, and there is some sub IL, sub, what do you call, sub retinal, what do you call, the the stain is there. So the first, coming to the causes, I think one, we actually, before actually going into stain, we had discussed in the previous surgery, in the previous episode also, that we can actually try avoiding it by actually initially the initial push or the initial pressure, which actually should be, like the initial dye should be actually pushed out, and then slowly when you go in, you can do it one. Secondly, some people have tried, actually they try to use the initial injection is actually put up on the light pipe. Like you can just throw it on the light pipe and then slowly it can trickle down and you can go on with that. The third way you can actually avoid this by actually using a glass syringe, where this initial force which actually happens, that doesn't happen in the brilliant blue is slowly, and in more controlled way it can be injected. The fourth thing is the syringes, actually they have a valve at the piston. So some syringes without the valve also have better control over it. And last time also Dr. Kushal had explained about Duer bowl cannula, where we have these cannulas which have the egress of the what do you call, the dye actually happens from the side bore which is there, and so that can actually prevent these sort of injuries. So, and secondly, we can actually sometimes have, this is related to your case. Sometimes in macular hole surgeries, what we tend to do is, if you have a larger hole, we tend to do an FAE. And post FAE, we try to restart the infusion. So in those conditions also, if you kind of have a sudden change in the hypotony suddenly happening. So at those times also, the infusion cannula, the infusion which starts off, it can actually cause a retinal damage, retinal tear. So having actually the infusion pressure on the lower side may also help in those sort of complications to be prevented. So these are some things which I wanted to point out. Anything else, Dr. Bhavik, if you want me to mention about, or the other panelists can talk about?
I think you covered the topic comprehensively, like excellent points. We'll move on to the further questions in the same video. So, what video, Dr. Anirban, you showed that you are injecting the gas with the help of with the help of a syringe. Okay, towards
Right.
it, right? So
Right.
there are
Yeah.
yeah. So this technique per se, like there are various techniques to inject the gas. So I would like to reflect upon this point of let us take a step back and zoom out and let us look at what are the ways in which you can inject the gas during either say a superior break in a reg RD or a macular hole patient. So, Dr. Kushal, would you like to highlight us about various techniques of gas injections during VR surgery?
Thank you, Dr. Bhavik. Brave surgeries, Dr. Anirban. So we all know during our conventional teachings that most of the times we have been seeing and using 50 cc syringes connected with the infusion cannula. So that was a conventional way. Obviously, the only other side of this type of technique was that the gas we wanted, it was a non-expensive, but it used to stay for a long time in the eyes. And these are the surgeries like the macular holes, if we talk about specifically, where a tamponade of maybe even 10 to 14 days is sufficient. So the conventional technique was described in literature as fixed concentration technique. So either we prepared 14 percentage of C3F8 or 20% SF6. But then there are techniques like fixed volume technique, where after finishing off your air fluid exchange, you remove all these sclerotomies, use either take sutures or if they are self-sealing, you inject directly your pure gas inside the air-filled vitreous cavity. So if you are using C3F8, it can be somewhere around 0.6 to 0.8 cc. So, or if it's an SF6, then it can be somewhere higher up to even 1 cc as well. The third technique which I would like to emphasize is been described by Irvin Group. So they have used and they have published on the outcomes of 2 cc of pure SF6. The only difference was that they had used the infusion cannula as a vent. So once you take off your trocar systems from the supratemporal and the supranasal ports, you inject your 2 cc of SF6 pure gas inside the air-filled cavity. So the excess of the intraocular pressure rise can be controlled by the infusion cannula, which acts as a vent, so that later on, if you come to know that the the gas is significantly high, so most of the gas will be actually egressing through the infusion cannula, and that can be removed at the last stage, and they could also get similar results compared to the conventional techniques. So I would describe these three techniques. The first one is a fixed concentration technique, second is fixed volume, and the third one is the using the infusion cannula as a vent.
Yeah.
Thank you.
Thank you, Kushal. So just a point I want the listeners and the viewers to understand that in the fixed volume technique, what Dr. Kushal mentioned, you may have to alter the concentration of the gas that you inject depending on the axial length of the eye. Okay, so in the fixed volume concentration, you're injecting zero point 0.6 to zero point 0.8 cc. That is for a 4 cc amount of vitreous. However, if you have high myope eye with a say 29 millimeter, 30 millimeter axial length, and the volume of the eye itself is 6 cc, the amount of concentration that you inject is eventually lesser. So you may have to end up injecting more amount of gas that you need to calculate. This is the only thing what you need to think of when you use a fixed volume concentrator.
Yeah, one thing I do usually is also I try to close the cases prior to injecting at a low IOPs. Say for example at somewhere around 15 millimeters of mercury or 10 millimeters. So based on the axial length, so that we can inject high volume without having significant rise in the IOP at the end of the injection.
Okay. So we'll go back to the first case for Anirban actually. So the first case what we had is not understanding, which happens quite frequently, or when you are constant, when you are operating for the first time, second time, your focus is only on your forceps and you do not pay attention to your surrounding. And if you saw in the video as well, it was a very fast movement which was happening after lifting of the flap and then the pulling the flap towards the macular. It was a very swift movement. This has to be a controlled movement, what was shown and what needs to be. And when you're going in a circular motion, you have to lift up the forceps because, as explained earlier, it is a spherical surface there. So what happened was there the forceps hit the retina and caused a retinal break. So now my next question is to Dr. Chitranjan actually. In this case, there was a cautery which was done, diathermy which was done for the break. Clot there, and that's it. You don't do anything. You can remove the blood clot, and you may or may not laser. That is the alternative technique there. So, what my question is: do all retinal touch while appealing ILM lead to a break? That is the first thing, and subsequently to a RD. And do we need to laser all of them? This is to Dr. Chitranjan.
So nice question, Dr. Bhavik. So the answer is no. Not all the breaks lead to retinal detachment. Neither all the breaks needs to be lasered. Like what Anirban has shown, he has shown two videos. The initial video, it was well inside the arcade, right, in the posterior pole itself. So if we have a touch in the posterior pole itself, we did not do a kind of extensive laser which will be kind of approaching towards the center of the focus. So that's not very much needed. In that particular case, probably diathermy was done because it was affecting one of the major vessels, if I'm not wrong. That's why they did. Otherwise, diathermy also is not needed in the posterior pole because it will be a minor vessel, kind of tributary injured. So in the posterior pole, it's not needed. However, in the second video, if you see, it was well outside the arcade, out around 1 dd away from the border of the optic disc. There, if the hole is there, you can do laser. There is no problem. You can do laser. One thing, ensure that the ILM is peeled, and we can, as you told, we can leave the kind of blood to clot over there also. I'm telling in the posterior pole if it is there. we need not do laser in all the cases. However, if it is outside the arcade to repeat, we can do a laser.
Thank you, Dr. Chitranjan. So maybe the last question in this for this aspect is that we saw that gas injection which was done. However, if one is not confident or the patient is unable to maintain a position, silicone oil you should not refrain from injecting, because here macular hole is not the primary pathology now. You do not want a retinal detachment to happen as well. So, Dr. Avnish, in such cases, if there is a retinal touch or leads to a break and a major vessel is involved, would you prefer an oil or a gas as a tank plan?
For this particular case, I think we had a good ILM peel and we could actually, I mean, lasering as Dr. Chitranjan had explained. So if we can actually have a good, like what on table before actually finishing the case, if the retina seems to have attached nicely and the break is not that big, I would still prefer to go ahead with the gas and just come out. But if you have a larger break where you think that the flap of retina may be in a situation where you have a doubt, always go ahead with the oil because it will give you a better visualization of the retina. Because sometimes we tend to put a gas and maybe even once the gas starts to come down, we can have full blown retinal detachment. So if it's a trivial small sort of within the arcade sort of a break, I think if you are able to see that it's nicely settled and I would not want to put a oil in that case. But if it's a larger sort of an retinal tear, I would prefer to put an oil and maybe we can always go back and do an SOR. Be safe in that front, I feel. Yeah.
Yes, thank you, Dr. Anirban, thank you, and the panelist for your comments.
Thank you.
We'll quickly move on to the third case today, that is Dr. Alpesh Rajput. So Dr. Alpesh Rajput will be presenting his third case. So Dr. Alpesh Rajput is currently finished his VR fellowship from Gedder Institute and currently working in his own private hospital in Rajput Hospital, that is in Ahmedabad. So over to you, Dr. Alpesh.
Yeah, thank you very much, UC organization, to giving me opportunity. I am audible?
Yes, you are. You can share your slide.
This is the case of 70-year obese female, which she was underwent classical ILM pill with the C3 effect gas 3 months before. This is the OC. You can see the open hole even after the primary surgery. So straight away I went ahead with the blue dye, trying to find out the ILM flap. As you can see, the circular ILM was removed from arcade to arcade. I am searching for to raise the ILM from the inferior arcade, now from the superior arcade. So this was the primary plan, to make the free ILM flap either from the east or from just above from the arcade, which I was unable to get. So I was just tense and I just shifted to my second plan to get the autologous retinal graft. To start with, I started from the superior arcade. As you can see, this is the endothermy I am applying. It was thoroughly done. And after that, horizontal scissors was used to separate the flap. And now it was removed from the retinal bed. As you can see, I am holding with the ILM forceps. My idea was to keep the tip of the slight edge of the ILM, this retinal graft attached at the bed. But unluckily, it was totally separated, due to jerk. And I do not have kept any PFCL. As you can see, my graft is in my hand. And now it is floating inside the vitreous cavity. Due to the fluidicity, one port is the 23 diap gauge. Now PFCL is applied. I am trying to keep that graph. Now it is again floating inside the vitreous cavity, and finally I have lost it. So I went to move to the choose the another bed for the retinal graph. This is just beside it. Endodiathermy applied. PFCL has already kept this time. And now it is separated with the ILM forceps and bringing below the PFCL bubble towards the recipient side over the macular hole. So this time I am very careful, just trying to keep over the macular hole, and finally I have kept it. So it is nicely over the macular hole. Now barraging both the retinal graft bed, and now final time comes to remove the PFCL. Yeah. So this is what I was just about to remove the small amount of PFCL and keeping the central amount of the PFCL over the macular hole. But due to my extrusion, my graft has come inside the extrusion fluid. So this is now second graft I have lost. And I do have one reservoir of the earlier case of the AMG. This is what I am using is dried amniotic membrane. Yeah, you can see this is moving. I kept it little large, trying to remove the PFCL. With the fluid handle, I just move that graft over the macular hole. This is what I am trying to do, the 360-degree retinal massage to get maximum benefit to close the macular hole. And after that, I did the FAX, and finally, that amniotic membrane was kept over the macular area. Try to dry the retinal bed area. Yeah. You can see I have got the small kind of bleeding just beside the macular hole. This is the final FAX. This is the pre-op OCT. And this is the post-op OCT. You can see this is the area I have touched, and nearly type 1 closure, but not through the vision has slightly improved. We can say around 6/60.
Okay. Yes. Thank you, Dr. Alpesh. Once again, a very courageous and a daring video. I would like to put a disclaimer here that do not try this at home or in your surgeries before you are trained completely in obtaining a retinal graft. So Dr. Alpesh has had several experiences of using a retinal graft. That is one of the reasons that he went in for a retinal graft in this case of chronic macular hole. So we'll come back to you, Dr. Alpesh, in the part of it. So before we move on to discussing the different options available, I would like to ask Dr. Avnish that what are the various options for large chronic macular holes, and in what conditions you come across large chronic macular holes?
Yep. Thank you, Dr. Bhavik, and
First
Dr.
of
Alpesh,
okay.
nicely managed somehow. So coming to your first question as to what are the conditions which will feel kind of see these large sort of macular holes. So the first thing we actually tend to see them in is in high myopes, or maybe they have associated posterior staphyloma. We can have them in, those traumatic macular holes, or maybe macular hole associated with a retinal detachment. So these are some conditions where, you tend to have, or maybe a persistent macular hole where we have tried doing multiple surgeries, still the hole has not closed. So these are some conditions where you can actually have a very large hole. Now coming to the techniques where you can try to actually close these sort of holes is first is those conventional ILM flap techniques which started with, then followed by free ILM flaps. Then you can actually have AMGs and then followed by neurosensory retinal grafts, which Dr. Alpesh was talking about. And other things which we need to understand is when we're actually kind of mobilizing these free flaps, or maybe the AMGs, or maybe the neurosensory retinal grafts, we need to stabilize it onto the macular hole. So where the idea of the perfluorocarbons and the viscoelastics comes into picture. They have used what you call something called as the growth and enhancers, or maybe what you call the uh, transforming growth factor beta 2 sometimes, or maybe you can use a platelet rich plasma to actually plug in these sort of macular holes. So these are some techniques which we can actually do, and I think with further question we'll be able to elaborate the techniques. Yeah, Dr. Pavik.
Yeah, thank you, Avnish. So, Dr. Alpesh, one question is there, like what in the comments also we're getting. So, after you saw the patient who had a recurrent hole or a non-closure of the hole, so I'm not sure it's a recurrent hole or non-closure of the hole. In the previous meeting, we explained what is the difference between the recurrent hole and the non-closure of the hole. So, in this case, what made you go for the retinal transplant altogether or autograft altogether?
No, first of all, I will just try to get the ILM flap by anyhow. If during the surgery, if I am unable to get that flap, I will just try to get the retinal graft above the arcade, that is mainly from the superior arcade, and just very close to the macula. Because we shall try to get the near macula anatomy to get the best functional visual outcome. That has to be the main goal during the retinal graft. The problem with any graft, either AMG graft or ILM graft, we need to hold over the macula. So that we can do only with the either Visco, PFCL or some instrument. So for most of the time, I use the forecourt, so I can hold my retinal graft with the help of ILM forceps, or sometimes the scraper or the Tano scraper what we are using, or sometimes the finish loop, because our other hand is free to repress that or press the graft over the macular area during the FX. If during the FX we did the full or the total FX, it is not moving, it is very unlikely to move after the any gas or any endotamponade. So this is what my thought.
Yeah, that's okay. Okay. I was trying to say because it's, as Dr. Avnish explained, the various options before you go for a graft as well, right? Don't go for a graft. Suppose if at all in a very large hole and multiple surgeries have occurred and one has to do a graft. So, Dr. Kushal, this question is for you. Uh, what is in your case an indication, an actual indication for a retinal autograft? And like there are other questions in the chat box, technique of harvesting the graft and placement, because we need to place the graft also in the correct side. It should not be reversed. So that is your question for you, Dr. Kushan.
Yeah, thank you, Dr. Bhavik. So I also believe that whatever we do, we have to start from the least manipulative options of the techniques. So obviously there have been cases that such cases the people have tried to take an autologous ILM from somewhere near the arcades. So having done those techniques, if nothing works, then definitely at certain point of time, you can think about taking the graft. But the most critical thing about harvesting a graft is the site and the correct technique. So one of the techniques is what Dr. Alpesh showed, that directly you take a graft from the attached retina. So preferably the technique should be a bimanual one, because the control with a unimanual technique cannot be always as per expectations. So it's always better to go ahead with the bimanual technique. So in those techniques, usually we give laser photocoagulation burns, and those are the high powerful thickness burns rather than the diathermy, which Dr. Alpesh showed. Because sometimes a diathermy might poke into the choroid, and sometimes it might induce a paradoxical bleed. So that is number one. Secondly, there have been options where we can use a vertical scissor rather than the horizontal scissor to harvest the graft. And using the bimanual technique, we can always use a forceps along with the vertical scissor. Another technique has been described where we induce a localized detachment using the subretinal cannula, and then also we can harvest the graft. Now, in this technique, which is very critical that we don't lose the orientation of the graft, because we once harvest, we never know whether we have put it upside down or the routine ones. So the techniques have been described there. The authors have also used an internal limiting membrane peeling surrounding the harvesting area, and then they have taken the graft. Now, whatever said and done, all these things, once a graft is partially harvested, you have to inject PFCL till the graft is partially or fully covered under it, so that once it is detached from the area, you can slide it under the PFCL itself. And occasionally there have been articles where either in autologous peels or the grafts, even if you have an opportunity to leave a thin film of PFCL, they say that after finishing the air fluid exchange, the PFCL usually gets evaporated because of the high vapor pressure, provided it is not a big bubble and just a thin film of PFCL stays over the graft. So that can also assure you the stability of the graft. And there has been a question regarding the trephines. So this has been recently described by Dr. Rupak Kanti from BBI Foundation, where they have been using the dermatologically used trephines. And what they claim is that they are harvesting the graft almost zero point 0.5 dd larger, or maybe 1 dd larger size than the size of the macular hole. So these are my thoughts.
Yeah, thank you. So as you correctly mentioned, when we do retinal autograft, is obviously don't have much experience, maybe just two cases or so. But when you do it, you make sure that you take a little larger size of the graft because the graft tends to shrink. So, however, this being an invasive procedure, and we know understand that the outcome because the alignment of the layers, we know fovea does not have the inner retina, and we are going to put a full thickness retinal graft there. Before going on to a retinal graft, uh, one would think of doing a non-invasive procedure. So that is in the terms of using a capsule, the posterior capsule, the patient going along with the cataract surgery, or an AMG. So this question is for Dr. Chitranjan actually. Dr. Chitranjan, when would you consider AMG, and what are the indications, how to use it, and how are the outcomes compared to autograft?
So, amniotic membrane grafting is one of the many choices described for the failed macular hole surgeries or chronic macular hole or all these large macular hole, all these surgeries. Others being the retinal transplant and the platelet plasma and posterior capsule, lens capsule, and all others. So how amniotic membrane grafting is different? Honestly saying, I have not done any surgery with amniotic membrane. Whatever I'll be telling, what I have seen in the videos and read in the literature. So a large group of surgeons from Italy actually, they have published recently in the scientific reports. What they have told, out of the 40 eyes of failed macular surgery, macular hole surgery, whatever they have done, almost 100% they got good anatomical result with amniotic membrane grafting. So it was a bimanual Chandler assisted surgery with PFCL. They used PFCL. After that, they took the amniotic membrane graft inside. They used a punch outside only to make the size of the graft to be around either 1 mm or 1.5 mm, depending on the size of the hole. And it should snugly fit to the hole. It should not be too large or too small. If it is too large, actually the edges of the graft will roll inside centripetal, which will not serve the purpose. And it is, if it is very small also, the kind of migration of the photoreceptor will not happen. So it should be of appropriate size. And another thing they emphasized it, the epithelial side and the chorionic side, you must identify these two sides. The epithelial side should be towards the vitreous cavity and the chorionic side should be towards the RP. So how to identify? It's not like what we used to do in the pterygium surgeries to kind of mark it or something. We cannot do that. However, what they have told, if you go inside with your forceps itself, the chorionic villi you can see, and the sticky kind of nature of the amniotic graft you can find out, which should lie towards the RP, and the other side should be facing towards the vitreous cavity. That's how you will find it out. And they have shown not only the good anatomical result, also the functional outcome. Some cases the visual acuity improved, some cases almost all the cases they have shown the microperimetry and adaptive optics, where the improvement, functional improvement was there in microperimetry, especially at the edge of the hole. They have shown that the sensitivity improved, and they have done OCT and OCTA as well. So yes, amniotic membrane grafting is one of the methods where we should go in all these refractory macular holes.
Yes, thank you, Dr. Chitranjan. So this brings us to the end of this today's session of episode 18 of Late Night Retina. So just a quick recap of what we did today, or what we understood and learned today, is that from Dr. Hungda presented his technique of a semicircular flap along with the use of PFCL and a viscoelastic, which showed a 100% closure rate and give us inputs into this technique. Subsequently, we saw several complications which are presented. So we are thankful Dr. Anirban and Dr. Rajput for actually presenting those videos. Dr. Anirban's cases helped us understand what is a jet stream injury and how we can prevent it and how to manage such cases as well. And subsequently, what Dr. In the second part of the case, what we discussed was how one should ensure or remember that the surface of the eye is a sphere. Only that one geometry of the eye will help us prevent complications. And subsequent Dr. Rajput's case, we understood that retinal autograft is definitely a good technique. However, one needs to practice it and understand what indications are required. And one has to use it maybe as a last resort. And if not, there are other options which are available for a chronic macular hole as well, like use of AMG, which he nicely managed towards as the end of the surgery, and he showed a very good successful outcome as well. So thank you everyone for joining us and being with us, and thank you for the panelists as well. We'll meet again soon for episode 19. Have a good night. Thank you.
Thank you.
Good night. Great presentation.